Yes, I was waiting for that. Hi, good afternoon. It is afternoon here in Peru. Um, I'm so happy for today. Today we have Jacobi Medical Internal Medicine program with us. They're going to present a case and discuss a case. I remember last year was amazing. They were here too. So well, my name is Kiara. I'm a medical doctor from Peru. We were discussing about weather here, and like right now in Peru is very, very hot. I can I can't stand that kind of temperature right now. Um, but yeah, it's sunny, so it's a happy day. Also, I missed the finals, but I listened that Argentina won and Argentina South America representation, and I'm wearing a light blue shirt because of that. Yeah, I'm so happy about that. So yeah, so maybe Rafa can introduce himself and yeah, congratulations. And yeah, and we can continue with the case.
Hi, everyone. Thank you, Kiara. My name is Rafael, and I'm a medical doctor from Brazil. And today we have this incredible program that we had last year. So exciting to have you guys back. Just for you guys that don't know the model, we'll be discussing a case with them. And then in the end, we'll open the mic for the audience to ask questions about the program. So thank you, everyone, for coming. And now I'll pass the mic to Ravi, who will be leading this session.
Okay, welcome everybody. I'm really looking forward to a fun-filled session with our guest program today, especially this case. So I'm going to implore everybody to possibly put your thoughts in the chat, and we'll see what we can come up with. So it'll be a group effort, so don't be shy. And if you're able to unmute your mic, please go ahead and unmute and let us know what you're thinking about. And hopefully we can get to the diagnosis. And always remember, it's the journey and not always the diagnosis. Sometimes not able to get the diagnosis, but the journey can be full of a lot of teaching points. And I share the same sentiments. Incredible game. I have possibly all my energies expended. I'm originally from England, so a big football fan, we call it football, and a great admirer of both teams, Mbappe and Messi. And it's such a fairy tale ending to see Messi go into the sunset, winning a World Cup. And soon he will be playing in Miami here in the US. So maybe we'll get to see him at a couple of MLS games. So mic over to our guest invitees this morning. Go ahead. Or this afternoon, sorry.
So hi, everyone. Thank you so much for having us. We're actually really excited to be here. We've been looking forward to it since last year, since the other guys did it. So thank you so much. So my name is Melissa Burgess. I am originally from Dominican Republic, and I did my medical school there. And like these guys here, I'm currently a fourth year chief resident here at Jacobi, and I'm really interested in pulmonary critical care. So that's what I'm going to be going into next year, and I'm going to UCSF, which I'm really excited about. So nice to meet you all. Pass the mic.
Hello, everyone. My name is Manuel. I'm actually also from the Dominican Republic. I'm a fourth year medicine chief here at Jacobi. Very grateful for these past 4 years here. And I'm also interested in pulmonary critical care, and I'll be going to Chicago next year for a rush. So I'm very excited about that. Going to colder weathers, as to say, right?
Hi, everyone. My name is Nathaniel. I was born in New York here, and Jacobi has a special Sabbath track that I'm part of, and a huge fan of the clinical problem solver. So it's almost like a dream to actually be on it. It's like it's very, very surreal. And I am interested in cardiology, and next year will be at Westchester Medical Center for my cardiology fellowship.
Hey, hi everyone. My name is Israel. Despite the name, I'm actually not from Israel. I'm from Nigeria. I did my med school in Nigeria, moved to England for a while before moving to the US, and I'm currently one of the fourth year medicine chiefs here in Jacobi. I'm interested in cardiology, and I'll be joining the Yale School of Medicine next year for cardiology fellowship. Thank you guys for having us.
Okay, so yeah.
Amazing, amazing. So we'll start off with the case. Can we please have the first aliquot?
Sure. Awesome. So I'll preface it by saying that this is somebody these guys took care of 2 months ago. So we're really excited to kind of bring and share his story with you guys. So I hope you guys like it. So I'll start. So this is a 40-year-old gentleman who presented to the emergency room with a chief complaint of toothache, body ache, and fever. So some of the details I'll go by pretty quickly because we want to be able to get to the meat and bone in the middle of the case. But I'll just summarize the HPI. So this 40-year-old gentleman described that a week prior to presentation, he described a toothache that started after biting really hard on a piece of meal. Over the pain began and it was constant and progressively worse over the next 3 days. And then he also started to develop subjective fever and chills accompanied by full-on body aches and myalgia, hoarseness of voice, and occasional phlegm production with cough. He denied any ear pain or any sore throat, and the rest of the review of system was actually negative. So for his additional past medical history, he had a past medical history of hypertension and alcohol use disorder. However, he had abstained from alcohol use for 2 years. His past surgical history was denied, nothing. For medications, he was only taking Tylenol as needed for his fever over the last 4 days. Otherwise, he hadn't been taking any medication. And for his social history, so this gentleman was originally from Mexico. He had immigrated to the United States 20 years previously. He was a never smoker, denied any recreational drug use, and was not sexually active currently, although in the past he was exclusively sexually active with women. He currently worked in a commercial shop, and his travel history was remarkable for a recent trip to Pennsylvania 2 weeks prior, where he stayed in a hotel and engaged in some recreational hiking. All right. So I can take a pause now if you guys have anything like you want to think about from that, or I can continue to the physical exam in the emergency room. What do you guys think?
Yeah, absolutely. Thank you, Melissa. That's great. That's a lot of information there. I'm going to stop there and see if anybody has any ideas. There's a lot to grasp there, but it's fascinating. You got toothache, you have this fever, you have body aches, you have hoarseness of voice. Anything comes to mind? Very intriguing. Hans, you have some great thoughts there. Could you care to share?
Yeah, that was already mentioned by somebody else. An infection following the toothache. It sounds a little bit like Ludwig's angina, if I remember from our STEP exams. And it's a subjective fever, chills, hoarseness. So something's going on in his throat. And now I pass the mic back.
Great, thank you, Hans. Always great to hear from you. Yeah, you bring my attention to this toothache, and then looking around the vicinity of where the tooth is, it's attached. I don't know if it's the lower tooth or the upper tooth, but lower teeth can present as routes for infection. So specifically, if you have a broken tooth, it can be an entryway for oral flora into the gums, and from the gums down to the spaces of the floor of the mouth. And then this hoarseness of voice, how can you relate it to this? Any ideas? Jamie, you have some great bugs. But before that, any ideas? I'd love to hear what you're thinking, and then tell us about the bugs that you're describing in the chat. Oh, Shema. Oh, sorry. It may have come across as Sammy, but yeah, sorry.
No problem. So when I read about the abuse of ethanol, I was thinking of Klebsiella, actinomycosis, and nocardia as notorious ones, and also especially when this person also has rotten teeth. that was from one episode with Dr. Lila Will-Colburn, I remember. Yeah, and for the hoarseness, I think, as we know, upper airway infections like angina, as Hans also mentioned, can go in with hoarseness. And also seeing that he has fever. And so I think sometimes I remember Fusobacterium, Fusobacteria are also very notorious. So these are the most common bugs that I think of. Yeah.
Wonderful, wonderful thoughts there, Shema. Yeah, I'm absolutely right on your path there. That looking at putting all this together, this pain, this hoarseness, we're probably in the locality of the oropharyngeal region. If we have a dental, somebody mentioned, I think Hans mentioned, dental abscess can morph into Ludwig's angina. You could specifically also have something called Lemierre's syndrome. You can also have retropharyngeal abscess. We don't even know if we're dealing with a tonsillar abscess as well. So this can always anatomically migrate to the retropharyngeal, parapharyngeal areas too. So these are some early thoughts. I think it's kind of early to think about which kind of bugs, alcohol. We always have this system one thinking, Klebsiella for pneumonia, aspiration pneumonia, and anaerobic organisms. Yes, nocardia in the mouth. What could localize in the mouth? Nocardia, actinomyces. As we get more details, we can then focus in on what could specifically be the cause, but we need to know what is the syndrome at hand. So we'll need to consolidate this further with more aliquots, and then we'll see where we can drop our diagnostic anchor. So I'll send the mic back to Melissa for more aliquots.
Perfect. Awesome. Those were all incredible differentials and already kind of hypothesis generating, which I love. So I'll continue and give you a little bit of the physical exam in the emergency room. So notably, his vital signs were notable for a blood pressure of 101/65, a pulse rate of 128, and a fever with a Tmax of 103.2 degrees Fahrenheit. His head and neck examination was notable for an erythematous lower gum with induration and purulent discharge at the base of the lower central incisors on the buccal side of the gum. No discrete abscess was observed. However, they did notice some mobility of the 24th and 25th teeth. So those are the anterior incisors. The respiratory status was very stable. His lungs were clear to auscultation bilaterally, very unlabored. His heart auscultation was notable for tachycardia, otherwise no adjunct sounds, no murmur, rubs, or gallops. For his abdominal examination, his bowel sounds were positive. His abdomen was non-tender, non-distended. There was no palpable organomegaly, and his skin inspection was within normal limits without any evidence of rash or other additional findings. I will also add that his neck was, there was no neck swelling, there was no significant lymphadenopathy, no facial swelling or other accessory findings. And I do have a picture of the image of the lower incisors and the lower jaw that I might be able to quickly just sneak a share. Let me see if I can do that. So you guys can take a sneak peek. Let's see. All right, let's see. Is that okay?
See, yeah.
All right, let's see if that shows up. All right, let me know if you guys see our screen, our picture.
Yeah.
We see it.
Great, awesome. So what we're seeing here, like I mentioned, is a quick image of the lower jaw. You can see poor dentition. You can see a lot of plaque overlying the teeth. You can see this erythema of the lower mucosa, and you don't see any kind of distinct abscesses or purulent drainage in this image, but it was reported on prior descriptions. All right, so we'll take it back to you guys. And I'll give you some of the basic labs that they did in the emergency room. The CBC had a white blood cell count of 3.5, a hemoglobin of 13.7, and a platelet count of 280. His chemistry was fairly unremarkable. Sodium of 133, potassium of 3.2, a chloride of 93, a bicarb of 28.3, a BUN of 10, and a creatinine of 0.3. His liver function tests were notable for an AST of 50, ALT of 31, alkaline phosphatase of 81, and an albumin of 4. His UA was within normal limits, and those are the initial labs that we have for him. There's also an X-ray, which was fairly unremarkable. No evidence of infiltrates, no effusions, no consolidation, and an appropriate technique. So fairly negative in all respects. So to kind of finalize this first part of the presentation, OMFS was consulted in the emergency room. He underwent a teeth extraction and was admitted to medicine because of suspected sepsis and to receive IV antibiotics. He was started on Unison. Despite this, the patient continued to have intermittent fever as high as 103 during his hospitalizations. So that kind of, I'll take a step there and kind of give it back to you guys. Now that the tooth is out, this patient is still sick looking. He's still tachycardic to 128. He's having very high fever up to 103 while on Unison. And this will be another opportunity for us to think about what is going on and where do we take it from here.
Okay, great. Any thoughts? I think Shema, Rafa, that is a great thought. Would you care to share that, what you put in the chat there?
Sure. So there's a schema that I really love, one of my favorites, CPS, which is the antibiotic failure diagnostic schema. And if you're having infection and somehow this patient is not recovering, you have to think about wrong bug. Maybe you're not covering for Pseudomonas, for example, and this patient needs to be covered. Wrong drug, or maybe could be the wrong dose, or maybe source control. For example, if you have osteomyelitis, you need to control the source and give antibiotics. Or finally, you can have like an alternate diagnosis. Maybe you're dealing with a vasculitis and trying to treat it with antibiotics.
That's absolutely wonderful. I wasn't really thinking that there. I'm thinking, okay, this Unison is a great antibiotic, and to cover oral flora, awesome for also pneumonia, awesome for any sort of anaerobic infections in intra-abdominal as well, is a great antibiotic. It's used commonly in peds. I remember there was a limitation on Unison being used in inpatient medicine because it was then specifically used in peds. I'm not sure if you have that at Jacobi as well, but we recently were able to get it back. So I'm thinking, yes, why now you've got sort of two simultaneous processes going on. Maybe the first process was the inciting event. You had this tooth, which allowed for introduction of oral flora into the gum, and then it set up shop in the gum and allowed to flourish a dental abscess. And soon after, it may have moved to something else. So if you have an abscess, like you mentioned, Rafa, so source control, we need to evacuate that abscess. I'm sure when OMFS went in, they were able to crack open, allow for drainage of any sort of bacterial material. Then wrong diagnosis. So again, two simultaneous things that are occurring. The first one we had was this dental issue. Now, what could it morph into? Again, abscess is the easy common denominator for source control. Anything like you have pneumonia, you have an empyema, you have polynephritis, perinephric abscess, you have cholecystitis. So what is the complication of that? Cholangitis. So any sort of purulent material abscess that can occur or can extrapolate into this ongoing infection in spite of giving antibiotics could be explained by abscess. And again, the other theory that we had going on that maybe there was seeding somewhere else. I also have to worry about, could there be bacteremia in this patient? This patient is just so terribly sick. There's ongoing fevers, there's tachycardia, there is a large amount of inflammation that's going on. So at this point, I also was thinking while Melissa was presenting, the examination of the throat really didn't raise any red flags. So palpating around, there was nothing ominous there, like a mass. There was no tonsillar enlargement. There was no pain. There was no trismus. There was no patient having any abnormal sound, stride, or anything like that. Something that could be an emergency. So again, we're going to shift our attention from the throat, maybe the back of the throat. Was the patient having pain moving the neck at all, Melissa? Do you remember? No. So I think that the throat is something I was thinking about, but it may have to bring my attention back to the site where the tooth process was going on. Palpating the floor of the mouth, was there also pain?
No.
No? Okay.
No
So
muffled
sorry?
No muffled voice as
no
well.
muffled voice as well. Okay. So, things in this sort of a case, you have to worry about airway compromise, stridor. If there's any, sometimes we think about drooling, dysphagia, there's pain in the mouth, there's pain in the angle of the jaw, neck stiffness. We had a case of CPPD and something called crown dent syndrome. Patient that had terrible time trying to move their neck. So nothing like that is occurring here. So I think imaging is the order of the day. Commenting on if anybody else has any ideas in the chat. Let me just see before I keep going on. Shema has a lot of ideas. I'm actually going to ask Shema to elaborate if she can before I keep going on. I kind of have a habit of mumbling, but Shema has some nice ideas I'd like to maybe explore.
Hey, I really love the discussion ongoing. I was also thinking about his sexual history. Like, as we know, some STDs can also manifest with angina, like syphilis. And also in terms of this crown dent syndrome, I also thought that this is a very nice idea. I remember from one VMR that it usually presents with very massive pain when they rotate the head. And I think in order to diagnose crown dent syndrome, you would have to make a CT scan of the first two vertebras of the so C1 and C2, because usually if we do a CT, we don't also do a CT of the neck. So this would be very necessary.
Absolutely. I think the answer may lie in imaging of the area. I think we're pretty close in localization of where the answer may lie. But again, I think here we're looking everything. If you filter it through inflammation, there's inflammation. I don't think there's anything sinister else going on. Well, when you had mentioned a 40-year-old with alcohol, we must think about oral malignancies as well, especially if the patient is a smoker. So alcohol and smoking does increase the incidence of oral malignancies, maybe also upper GI malignancies as well. So those are some things to think about. But here I don't have a sort of a flavor of a malignant process. But again, with the Y count, 3.5, not terribly high. If there is an abscess, sometimes with an abscess, you may not have a tremendously elevated Y count until you open up the abscess and allow the inflammatory process to then escape the area. But yeah, I'm a little troubled by that. Let me see the other lab results. AST 50 is a little elevated. AST doesn't always come from the liver. You must think about maybe is it coming from RBCs, hemolytic process? Can AST come from muscles like rhabdo? But it's not a terribly elevated number. So I think that's something I'm not really going to spend a lot of my cognitive energy on at this point. It's not really going to help me get to the diagnosis. Chest X-ray unremarkable. So again, nothing in the upper mediastinal region that could be moving up to the neck. Something like we always talk about these anterior mediastinal mass, the 4 or 5 Ts, and so on. And then, like Melissa mentioned, there's nothing in the neck that we can palpate on examination. So I think, like Shema had mentioned, getting imaging of the head, specifically the mouth and the floor of the mouth, I think will be very helpful. And then going back to I just want to mention about Unicin. Unicin is the trade name for ampicillin sulbactam, a great antibiotic, has a very broad range of coverage. It's a beta-lactam, so penicillin. It will cover mostly gram-negatives, no Pseudomonas, MSSA, not MRSA. It'll cover anaerobes, both oral and gut anaerobes, so Bacteroides, and also oral anaerobes. So you have a multitude of oral anaerobes like Peptostreptococcus and so on. So it's a very broad acting or broad spectrum antibiotic, and would be appropriate at this time for this, for something like this. Back to you, Melissa.
Awesome. So I'm gonna pass the mic to, I believe, Manuel. Oh, sorry. Israel.
One thing I want to comment on, I saw in the chat, Rafa mentioned about the EKG, because there someone was concerned about endocarditis. And sometimes you can have EKG abnormalities, especially if it involves the aortic root. The EKG was just sinus tachycardia, but there was actually no other abnormalities. There was no SDT changes or ischemic changes, and no blocks of any sort.
Oh, okay. Great, Nathaniel, the future cardiologist. Thanks for picking that out. Yeah, endocarditis is a great thought. It can be a systemic process, and it can always manifest from some simple inciting event like a cellulitis, like a oral pharyngeal process like this. Strep viridans is notorious from the mouth as well, so something to think about. Strep, staph. So any number of those. So yeah, looking at the EKG will be very, very helpful. Thanks, Rafa, and thanks, Nathaniel, for explaining that. Back to you, Melissa.
All right, great. So I would give us the second part. So great thoughts so far. Excellent differentials, and it's beautiful. So we thought about the same. We actually broadened these antibiotics to include ceftriaxone now and vancomycin. Subsequently, after that, the day after that, he developed diarrhea, right upper quadrant tenderness, with some rebound tenderness. There was no gradient. He remained tachycardic to like 140s. He remained febrile, temperature of 102.4 at the Tmax. His saturation was like 94% on room air. At this time, his alkaline phosphatase increased to 227. His ALT now bumped up to 116. His AST bumped up to 146. And he developed AKI with a creatinine of 1.4. He also developed worsening hyponatremia while on the therapy. The other thing that is significant was that it was now noted to be pancytopenic with a white cell of 1.10, hemoglobin of 10.6, and his platelet dropped to 62. At the same time, he was noted to have bands of 19%. On the peripheral smear, he was noted to have some schistocytes, low platelet count, RBCs with intracytoplasmic inclusions, left shift of the neutrophils with some vacuolated monocytes, but there were no blasts that were seen on the peripheral smear. Because of the intracytoplasmic inclusions that were seen on the RBCs, doxycycline was added to his medications. Remember, he went on a hiking trip to Pennsylvania, just sort of to cover anaplasma and Ehrlichia while we wait for the blood PCR to come back. He actually had a CT abdomen pelvis done, which was negative for cholecystitis. There was no liver abscess. There was no appendicitis. He did have hepatosplenomegaly though, and he was also noted to have lymphadenopathy in the celiac axis and portal hepatis. The soft tissue neck, CT of the soft tissue neck, like we had mentioned earlier, just showed that he had his mandibular incisors removed, but there was no ring-enhancing lesions or fluid collection in that area. Like someone had suggested, he actually did have a TTE done, which showed normal biventricular size and function, but there was no evidence suggestive of endocarditis. Now, 2 days after that, he actually developed a rash, which at that time was described as maculopapular. It was blanchable. It was non-pruritic, initially on bilateral upper extremities and the upper abdomen. And at the same time, he complained of right-sided flank pain with some concerns about that could be pyelonephritis while he was on ceftriaxone. So, and he continued to remain febrile, like very, very high temperatures, and also became hypotensive. Given the worsening clinical picture, his antibiotics was escalated to include meropenem and also continued on the doxycycline. Because of his hemodynamic instability, he was transferred to the ICU for continued care. Some labs that were sent initially, I'm just going to run through them. They were all negative. HIV, hepatitis, C. diff was negative. Blood cultures up until this point, 3 sets were all negative. Urine culture negative, COVID negative, flu negative, RSV negative. He had a DVT scan done, which was all negative. He had a CTPE done also, which was also negative. I have a picture of the rash just to show us if it's okay for me to share the screen, just to show us the rash and how it's progressed.
Yes, please.
So here is the picture of the rash. Can everybody see the screen?
Yes.
Great. So this is the picture of the rash. This is the upper chest and plus the upper part of the abdomen. We can see an erythematous, or we can see erythematous maculopapular rash. In that part, this is just a closer look at the rash on his chest. And this is on the upper extremity, just sort of becoming confluent at that time. It was actually blanchable at this time. And then this is how it progressed to include most of the upper part of the abdomen, the lower part of the abdomen, and it became sort of mobiliform, and it just kept getting worse up until this point. So at this point, I'm going to pause for us to sort of go through again and see if we're missing anything or what we can adjust or what we can add to our line of thinking.
Wow, Israel, that is amazing. So I think we all got to sort of take a step back and look, maybe do a, what do I call, a dragon-eye fly view, 10,000-foot view to really take in what is going on here. So a problem representation, while we kind of talk, I think I'll ask somebody if they can put together a problem representation, because there's so much data here and it's just very confusing what is relevant, what will help us. We have this rash, we have these lymph nodes, we have all sorts of things. We have these labs that are very invaluable. So how will it help us get to the diagnosis? What is important here? What can we discard in trying to get to what will help us or give leverage to getting to the diagnosis? But before we get going, I think Chiara had mentioned something in the chat, a question. Chiara, would you like to ask that question?
Well, at first I was thinking about tick-borne disease because of the rash and the liver compromise and fevers and of course of his recreational sports. But then that kind of rash that progressed to a more uniform rash, like I'm not longer thinking about a tick-borne disease, and it's very interesting because his symptoms worsened after he received his treatment for the apparent infection he had. So, as I think Hans or Shema told, this could be caused by a drug adverse effect more than the infection itself, maybe.
Absolutely, yeah. We may again have competing things that are occurring. So we have somebody who was started on Unison for the mouth, and this rash, mobiliform rash, I usually relate to a drug-related event. So Unison being a beta-lactam antibiotics are notorious for causing rashes. So let's explore what kind of rashes do you get. Somebody had mentioned DRESS syndrome. So the time frame is key here for mobiliform rash due to beta-lactams, also sulfonamides. Usually 4 or 5 days in, you will get this rash. It will also be, what's very important is to localize if it's including just the skin and not the oral mucosa, the genitals, the rectum. If it is involving the mucosal structures, then you may be facing something like SJS or 10. That usually occurs more of maybe longer duration of antibiotics. DRESS maybe 2 to 4 weeks into the course. And again, it would involve systemic features. So you may have maybe this liver issue. You see this AST, ALT, ALP elevation may be due to that. So DRESS, the patient hasn't been exposed for that long, so I do not think we have DRESS that's currently manifesting here. You do get one component of DRESS is eosinophilia. You may see it 50% of the time, so you don't always see it. Maybe on an oral exam, a board exam, you may see that in there, but in real life, you may not miss it. That's why DRESS was changed to drug-induced hypersensitivity syndrome. So with the rash, somebody had mentioned something like, I'm going to call on Shema again. She was thinking about tick-borne disease. What do you think, Shema? How could you fit tick-borne diseases within the scope of what's being presented here?
It was also especially about these inclusions in the blood cells. So if I see vacuolization in the monocytes, it makes me rather think of a bug. So I remember when we think of the combination of hepatitis and bicytopenia, for example, I always think of anaplasma and ehrlichiosis. And the rash itself, as we were talking about, like if it's more a rash that started on the trunk, I would also think of something like endemic typhoid fever. But what makes it a little bit unlikely is I would have expected that the temperature and the heart rate, that there would be this kind of a dissociation, which is called Faget sign or Faggot sign. So yeah, but so I have to say, I really don't know how to go further, but yeah.
Absolutely wonderful. I'm sort of, it's very nebulous for me. I'm sort of searching in the dark here, but I'm glad you clarified a few points there. Absolutely phenomenal thoughts there, Shema. So let's look at that, some of the labs that Shema had mentioned that we look for. So we have abnormalities in the CBC now. So we have, let me see, it's written down here. So the ALP, ALT, AST is abnormal. So does this signal that something primarily is going on in the liver? I was thinking, like, could there be maybe something that's hepatic in nature, hepatitis maybe? But the liver enzymes are not terribly elevated, where we see like liver enzymes up in the 500s to thousands. ALP being elevated, ALT and AST. ALP, when you think about that, there could be something space occupying within the liver. Could there be other viral illnesses like EBV, CMV can manifest with something like this? Fevers, high fevers, liver involvement. Also, although the ALP shouldn't be as elevated as this, with CMV, EBV, you could get CBC abnormalities like this as well. And then I would also look for atypical lymphocytosis, which I'm not seeing here. The pancytopenia, now I see it. There's so much data here, so I apologize if I'm not able to focus on anything. But pancytopenia, so the white count is terribly decreased. The platelets are down. BUN is 19. And then I also see that there was some schistocytes. So seeing schistocytes and low platelets, we have to start thinking of MAHA here. So if we think about primary, secondary MAHAs, are we dealing with things like TTP, HUS, DIC here, or do we see MAHA secondary to something that's extra RBC, like there could be something like a valvulopathy that's causing it? Could there also be something like scleroderma, renal crisis, some other of these causes? Malignant hypertension can cause schistocytes occurring like this. There's a comment here, Rafa is mentioning about the coags. Rafa, you want to ask that? That's very, very important too. If we have the coags, then we can shift into either one or two of these different diagnoses. But Rafa, do you want to ask that?
Yeah, so when I'm thinking about MAHA in the presence of schistocytes, I think about TTP, HUS, and GIC. This patient has no history of diarrhea and he's older, so HUS for me is less likely. TTP, you would expect like fever, altered mental status, elevated creatinine. But the thing here that I'm really curious about is the PTT, because it's both are elevated. You don't expect that in HUS and TTP, but you expect that in GIC. So are the cogs normal?
Yeah, so initially they were normal. At the time that these pictures were taken, the cogs were actually normal.
Okay, interesting. Yeah, Rafa, I agree. So DIC less likely. You also have low fibrinogen in that case. The coags are normal in TTP, HUS here. I think there was also diarrhea because Shane had mentioned, the patient was on antibiotics. Antibiotics can explain maybe the rash. Antibiotics can cause diarrhea. Diarrhea could be antibiotic associated diarrhea, or it could be the more sinister Clostridium difficile infection. And that can be very, very inflammatory. Usually we look for white counts that are north of 15,000, but here we have neutropenia here. Do we have the differential for the white count? Is it mainly neutropenia or is it lymphocytopenia?
So I think if I remember, it was both, but I think the neutrophils were more affected.
Okay, so sometimes with lymphocytopenia, that can be associated with viral infections. Viral infections cause a transient decrease in lymphocytes and then increase. But this is sounding more and more like maybe something bacterial that's going on there. So with the low platelets and the schistocytes, I mean, we're looking, TTP, you may not get all of the pentad. I know the creatinine is increasing, it's 1.4. With hyponatremia, that could be, I think that's secondary to the process that's going here. For a moment there, I was thinking hyponatremia, diarrhea, Legionella is associated with that, but here we don't have anything in the respiratory system to maybe support that hypothesis. And then the CT of the neck, and then also looking at the mouth was not significant. CT abdomen, there's hepatosplenomegaly and celiac axis lymphadenopathy. So how should we incorporate that into what's going on? Let's see. Shema, any ideas? I think you also putting in a lot of things in the chat there. Are you able to maybe help me along the process with this problem that we're facing?
So I was also thinking with the low platelets and the abnormal white count and this kind of diarrhea, I was also thinking of Salmonella enterica, which is sometimes we in Germany we say to this typhoid fever like, and this kind of trunk rash is also typical. Why I was thinking of Salmonella enterica also because this diarrhea, as far as I remember, it develops later. So as we saw this patient, he didn't have the diarrhea immediately. I know because it has something to do with the ileal region, which is getting swollen at the beginning of the infection, and later we have this kind of watery diarrhea. So yeah, but Hans also mentioned another bug with this intracytoplasmic inclusions. He mentioned about babesiosis, and as far as I remember, if you have a tick-borne infection, I think babesiosis can be a bystander in other tick-borne disease. So I think you can have two tick-borne infections at once because we are transmitted by the same tick. So yeah.
Oh, Shema, I really like that. Yeah. The salmonella causing this typhoid fever. I do remember it being thought of as causing a pseudo appendicitis because it does invade the lymph nodes of the gut. So there's something to think about. Babesiosis, or sometimes we call American malaria, you do get. So in the initial presentation, you mentioned this patient had been hiking and up in is this patient from Chicago, Northeast?
So he was originally from Mexico, but he had been in the New York area for years, and he only went to Pennsylvania 2 weeks before presentation for a conference, and there he engaged in some hiking recreationally. But other than that, he didn't have any significant travel history outside that place.
So Pennsylvania is pretty close, and if I remember Northeast, this area, we have a couple of illnesses, Lyme disease, babesiosis, sometimes located, it was called at one point Nantucket disease up in Massachusetts. And you do get these intracytoplasmic inclusion bodies. You had mentioned now incorporating that into this ginormous problem here. And then you could get a number of these other manifestations. But let's see. That is a competing diagnosis that we have here and could explain it. If I remember anything else with babesiosis that you may get, I think it was associated with animals, and I don't see any exposure to animals, but just the hiking does bring up this possible as an explanation of this. Going back to the salmonella typhoid fever, you get I remember rose spots from the steps, and it can manifest with hepatosplenomegaly. So what exactly, like this hepatosplenomegaly is very interesting. It could be explained by extramedullary hematopoiesis. The hemoglobin was, let's see, do we have the hemoglobin? We have the white count platelets.
Was 10.6. Hemoglobin was 10.6.
10.6. Okay, so not terribly decreased. But again, we do see hepatosplenomegaly in malaria. So in babesiosis, maybe we see it. We do see it in salmonella. So that could be also signaling that one of these two diagnoses is going on. Any other data before we have the diagnosis? Okay, that might help us get to the final answer. Go ahead, Israel.
All right, so I would pass the mic to Manuel now.
Yeah, so I think there, I've seen on the chat here, there's a lot of amazing thoughts, right? Right now, the patient's been here in the hospital, came in initially with some toothache, and then the hospital, of course, has been, as you can see, very complicated, right, by several things, having persistent fever now, multi-organ failure, having specifically the liver, being affected, liver enzymes, the kidneys as well are affected, and then now the bone marrow, right? We have this pancytopenia, and it's kind of the patient's getting sicker, and now is going to the ICU. And then we have a smear as well to kind of help us out. So some of the stuff, at this point, a week in, we're thinking that the patient, as someone mentioned early on, I think it was Shema mentioned, a fever of unknown origin, right? I think that's when we got to start broadening the differential. And I think it's always useful to kind of have it in 3 different points, right? If you're having a patient either with an infectious disease that we're not looking, and always taking account what we've been talking about, the geography, who's this person that we're taking care of. The other part is, malignancies. And the other part is, systemic rheumatological conditions as well. So essentially at this point, we got to send some labs out, which took some time. And we can go through some of them, all right? Israel just mentioned a couple of important things, like at that point they had ruled out DVT&P, which also can be another cause of like having fevers and having some organ dysfunction especially. So that was important. Endocarditis, although was with a TTE, was done, and I think that's important. And HIV was super important. What's one of the first things that we got to do. And C. diff as well was mentioning as well, because patients having abdominal pain and all that. But let's add up a couple of aliquots more in terms of this. And then, so in terms of rheumatological conditions, first thing we sent out was an ANA, which is very important with ENA and ANCAs were negative. Rheumatoid factor is important in fever of unknown origin workup, and that was negative. The complements levels C3 and C4 were negative, within normal limits, sorry, and anti-SMOOV was done, and that was negative antibodies. Importantly, quantiferon, right, for TB, right, was negative, and Fungitel was done negative. Brucella was also sent out. That was negative. Obviously, the patient didn't have too many risk factors for that, but that's important in terms of the workup for fever of unknown origin. Now, the CMV PCR was done. That was negative. Now, the Epstein-Barr virus, IgM was negative, but IgG was positive, and we had sent out a PCR for that. Now, I think everyone will mention a lot about parasites, and we did go into the microscope and look at it, and the blood parasites were negative. We looked specifically for Babesia, so I think that was a great thought, thinking about the pancytopenia and the liver enzymes, and then the trip to Pennsylvania. That's beautiful. Ehrlichia was negative as well, anaplasmosis. We had sent out syphilis. That was negative on RPR. Toxo, IgG and IgM were negative, and HSV 1 and 2 were IgM were negative. For all the infectious disease, and we had said Rocky Mountain spotted fever as well. IgM was kind of borderline 1.51, so that's still kind of so-so. And that's kind of for that part in terms of how you're differentiating your fever of unknown origin. So there were more things, now the patient is going to the ICU. Patient was still hypotense now at this point. Everyone was really worried about this patient in the ICU. And the patient, was placed central line. They were almost going to start pressors on him. And then we're sending some inflammatory markers, which I think were kind of important in this case. So D-dimer was sent out. That was 6,378. Our cutoff is 250, less than 250 here. Jacobi, ferritin was sent out, and it was 40,838. And triglycerides were done as well, 518, which initially came in with like 200 for triglycerides when he came in. And then some other, actually at that point, we were sending some other cytokines as well, but that takes a long while, right? So, yeah.
So before we get to the final diagnosis and last aliquot, we'll just say that a bone marrow biopsy was done. That will be talked about in the final aliquot. And we'll give it back to you for last thoughts.
Incredible. What's interesting is as we pull everything together, a light bulb sort of went off and I was like, I'm kind of interested in the ferritin. I put that in the chat there. And I'm glad Manuel did expand on that and give us that. And believe it or not, I've been blindsided by HLH twice on this. So sitting here, I've had cases like this. I'm like, holy cow, I've been through this roller coaster before and it was HLH. But again, I need to bring caution that HLH, again, could be primary or secondary. I doubt at this point we're dealing with somebody 40 years of age having a primary HLH. So we have to think about what is behind the curtain. So if you pull back the curtain, an HLH of that degree of magnitude, yes, if we look at, we were sort of waddling through, there's the pancytopenia, there's the fever, like you mentioned, fever of unknown origin, there's the splenomegaly, hepatomegaly. So all of this it does fit this criteria, which I don't happen to always remember, but it does fit the picture. Now, if this is indeed HLH, but we also have to be cautious when you have a ferritin that high, there could be other causes. Histoplasmosis can be one. Adult onset Still's disease could be another. So there's a number of different conditions where hemochromatosis, but again, this does not fit that picture. So if this is indeed HLH, and this patient does have lymph nodes as well, then we do want to look at this bone marrow and see if there's hemophagocytes within the bone marrow. I think there's also this hypertriglyceridemia that is part of this, and fibrinogemia that is part of this as well. And then what was the inciting event here? So that is something what I want to think about. And somebody had mentioned the illnesses could be causes of this. So we were dealing with one devastating condition, COVID, which was causing HLH or macrophage activating syndrome, or this cytokine storm syndrome. And then you have actually any of these viruses could be causing this picture. Malignancies come into play as well. So there could be certain leukemias that could manifest with HLH. But I'll send it back to you. Thanks for that, elaborating on that, Manuel and Nathaniel. And I'll see what you have for the final biopsy of the bone marrow to see if that gives us the diagnosis.
Okay, so exactly what you guys were saying. There was a concern for HLH, and therefore the patient was started on dexamethasone and etoposide. And following those administrations of those medicines, his fever curve improved significantly. The IL-2 receptor came back at 49,154, with the normal value being less than 858. Some other results that returned was his Epstein-Barr virus PCR came back at 39,400. Normal is 0. The intraoral biopsy that we mentioned at the beginning on admission actually came back, and it showed natural killer T-cell lymphoma. And he was... I
saw that, wow!
We're not done yet. So the bone marrow biopsy showed a hypercellular marrow, increased histiocytes with hemophagocytosis of the neutrophils, lymphocytes, platelets, and RBCs, which was consistent with HLH. there was 95% involvement in the bone marrow of natural killer T cells. And an EBR stain, which is seen in EBV-associated malignancies, was also very positive. So our final diagnosis was HLH that was induced by EBV-associated natural killer T cell lymphoma. His rash that he developed, we presumed that it was related to the penicillin use, his Udacid, in the setting of his Epstein-Barr virus.
Incredible. Holy cow. Wow. Excellent presentation. Melissa, Israel, Nathaniel, Manuel, so expertly presented. It's not easy to present all those different aliquots and all those different labs, and especially the sequence of events. It was just so expertly presented. I really appreciate it. Now I have to go back to the drawing board and revisit HLH, but thanks for bringing such a incredible case on a Sunday afternoon.
Someone mentioned early on HLH. I don't know who it was, but someone mentioned early on. I was like, "Oh, HLH," and I just shut my mouth, and I was just like, "Okay." But very early on, while Israel was talking, so I was very impressed with whoever wrote that. You're amazing, yeah.
And one thing that was like such an interesting journey that we went through this, like learning about this case, is like sometimes your patient will come with a dental abscess and they'll leave the hospital with a completely different diagnosis. So it's, even though it was fever and fever and fever, kind of have to always keep that differential open. If something doesn't fit, if the picture is, you know, the tip of the iceberg is indicating more beneath the surface, then we really have to do everything we can to kind of get to the conclusion. And these guys took care of him, so kudos to them for getting there. Yeah.
Wow, incredible. You're absolutely right, Melissa. What a roller coaster of a journey, starting from the dental issue and then moving through all of these different stages of this patient's condition. So kudos to the team that took care of it. And this just shows the kind of patients and cases that you do get to help at this residency program, which is Jacobi. So incredible. I'm really happy to be learning from all of you today. So now we have some time for questions, and I'm going to implore people to maybe type in the chat, or if you're able to unmute, please go ahead and ask all of our chief resident guests any questions that you may have about the program. I'm going to start while people type in the chat. So I'm going to ask each of you if there's anything about the program that you would like our viewers to know about. I mean, there's so many aspects, but maybe share one of your favorite parts of the program, if any of you would like.
Who wants to go first? Like,
I mean, I could go first.
Okay, all right.
I think, no, I'm not the boss. I think my favorite thing about the program really is the people. And it's two faces, right? The people, meaning the people I work with, and the patient population that I take care of. I think that's something that's sort of the most remarkable thing for me, and quite very heartwarming, especially sort of makes me want to come to work every single morning. I wake up with a smile that I got the opportunity to train and work here in Jacobi with amazing set of people, and also to take care of patients, the patient population that we take care of.
Yeah, I hate to kind of be repetitive, but I would say that's definitely my favorite thing about the program. We are IMG based, a lot of our IMGs, and we come from a lot of different places, and we learn a lot from each other's culture, each other's medical training, the different experiences that we've been able to see, the different patient population that we've been able to treat. And we have kind of a really proud tradition of medical education, not just with our faculty, but peer-to-peer teaching, and a lot of kind of self-directed learning, a lot of enthusiasm within teaching our co-residents, fellows, and medical students. So I think that's definitely been my favorite aspect of it, just like that tradition and that really enthusiasm that we bring when we're doing our day-to-day work. There's always something to teach, to learn, and to, kind of aspire to. So that would be my favorite part. And I hate if I sound repetitive, but it's true. It's true.
I actually wanted to say the people, so I gotta do something else. So I'll tell you, I think one of the favorite things is growth. If we were to use like one word, I didn't expect that I would grow so much as a physician and as a person, really. And I'm very humbled, as this role is saying, by the people we get to take care of from all kind of backgrounds. And we're all from all sorts of backgrounds, which I think it makes it a more enriching experience in terms of just not only personally, but also in terms of academically. Everyone comes from different academic backgrounds, so that also makes you have a more comprehensive and kind of at the same time unique care for these patients. And to be honest, what I feel about in terms of this growth, which is kind of one of my favorite things about Jacobi, is really this whole experience has been more than the sum of the factors. It's not just Manuel coming into residency and the experience, and then that's it. It's actually much more exponential, the whole experience has been, that you would expect from coming here. Yeah.
100%. I mean, we say we feel bad piggybacking on each other, but the truth is we all came prepared with our own thing to say, and without discussing with anyone else, yet every single one of us says the people. Like it's been unbelievable journey, and you know, it's hard work residency, but with the people that we have here, we have fun. And like this year has been amazing with like these colleagues, the best co-chiefs you can ask for. We have so much fun together. We learn together, and are, you know, we're going to stay in touch. And like that's I really think that's the best part.
Absolutely wonderful. And I could just say you are all truly representative of the patient population and the community surrounding your area up in the Bronx, right? That you're up in that area of New York, and you know, like Melissa, Nathaniel, Manuel, Israel, you all represent different communities, and I'm sure the patients are very happy to see all of you when you're taking care of them. A couple other questions. Could you talk about the ambulatory outpatient opportunities of the program?
I would be happy to talk about that. So yeah, so we have a 6+2 schedule, which means for every 6 weeks of clinical work, be it, you know, floors or ICU or elective, we have 2 weeks of ambulatory, which is great. We have it can help with patient continuity. It can help, you know, have a little bit of a breather from the heavy floor rotations. You got 2 golden weekends. And we have built-in QI curriculum in the outpatient setting, and also have a lot of clinics that our residents can rotate through. Some of our residents are meshed into the primary care track, which has a little bit more of a rotation in the outpatient setting.